In order to complete a thorough intraoral examination, the dental hygienist must first focus on 1. Recording deviations, 2. Identify the need for additional evaluation or referral, 3. Recognize conditions requiring immediate attention, 4. Prevent advanced lesions, 5. Provide a longitudinal record. The sequence for completing a thorough examination begins from the outside of the mouth in, from the top of the mouth down to the bottom, the floor of the mouth. The complete oral exam will include both visual inspection and palpation of the intraoral structures. The armamentarium used for this evaluation is the mirror, explorer, probe, and gauze. We first have the patient open up comfortably, and we assess the oral cavity proper, which is the inside of the mouth. We gently retract the upper lip and assess the labial frenum, then moving down to the mandibular labial frenum. You're looking at the frenum width and length, and for my patient, it is within normal limits. Moving to the buccal mucosa on the left side, adjacent to the second molar, is the parotid papilla, which houses the Stenson's duct. And we need to assess the salivary flow rate. In order to do that, we use a 2x2 piece of gauze and gently milk the gland, and you can see the salivary rate is fast and serous. And we do the same on the right side of the buccal mucosa. And we gently milk the gland again, and the rate is fast and serous. Moving back into the vestibule, which is another name for the moat of the mouth, we look at the buccal frenums as well, and up to the maxillary frenums. And they are bilateral on the right and left sides. Next, we assess the alveolar ridge. We use bidigital palpation, feeling for any exostoses or tori's. Moving up to the maxillary arch. It's all within normal limits. Then we continue on to use bidigital palpation on the buccal and labial mucosa. Next, we assess the hard palate. We look at the height, the contour, the color. We assess for tori's, lesions, ulcers, or growth. Our first landmark is the incisive papilla, which is located just behind the central incisors. It's a very small, round elevation of tissue. Next, we're going to move to the palatine raphe, which is a slightly elevated center line running anterior-posteriorly in the hard palate. And you can see on my patient it's quite prominent. Running horizontal off of the landmark is the palatine rugae, which is a series of elevations or wrinkles running side to side like branches of a tree from the raphe. That aids in the mastication process. Palatine fovea are found at the junction of the soft palate and the hard palate. The hard palate is easier to find due to the color, which is more white due to keratinization. We also assess the maxillary tuberosity, which is adjacent to the second or third molar, and we use digital palpation. We also use digital palpation on the hard palate, assessing for any tori's. Next, we will focus on the soft palate and the oral pharynx. We'll be looking at the color, the size, and shape of the arches. We'll be looking for ulcers or growth, and petechia, which is trauma to the soft tissue. The midline muscular structure that hangs down from the posterior margin of the soft palate is known as the uvula. The posterior pillar, also known as the palatopharyngeal arch of soft tissue, connects the palate to the larynx. The anterior pillar, or glossopalatine arch, connects the palate to the tongue. Next, we assess the palatine tonsils, which are masses of lymphoid tissue located between the anterior and posterior pillars. Next, we move to the tongue, and we assess the dorsal, ventral, and lateral surfaces, noting the color and size, checking for coating and fissures, assessing lesions or swellings that are compressible or indurated. We have the patient place their tongue on a moistened 2x2 gauze and gently wrap the gauze around the tip of the tongue. First, assessing the filiform papillae, which are hair-like structures covering 2/3 of the dorsum surface of the tongue. These are prone to stain and do not house taste buds. Fungiform papillae are larger, rounder, scattered papillae, more red in color, that house taste buds. Circumvallate papillae are on the dorsum aspect of the tongue, which consists to 8 to 12 large, flat, mushroom-shaped size papillae. They are in a V-shaped row, which contain taste buds. And you could just see the tops of them here. Next, we assess the lateral surface of the tongue and look for the foliate papillae, which are large, leaf-like projections on the lateral borders that contain taste buds. Next, we digitally palpate the dorsum aspect of the tongue. And we have the patient lift the tip of their tongue to the roof of their mouth. Looking at the ventral surface of the tongue, we have a lingual frenum, varioscosities, and tissue extensions known as plica fimbriata. To assess the floor of the mouth, we need to use bimanual palpation. Using the tip of your glove finger and 2 fingers of your overgloved finger, gently knead the tissue between the fingers and assess for any abnormalities or swellings the size of a grape, moving from the base of the tongue anteriorly. Next, we assess the retromolar pads, which are a triangular area of bone covered with soft tissue posterior to the last mandibular molar. And we use digital palpation as we did with the maxillary tuberosity. Continuing with our evaluation of the floor of the mouth, we need to assess the salivary duct flow. Sublingual folds are elevated folds of tissue extending medially along the floor of the mouth towards the tongue. These contain openings to the sublingual salivary glands. The sublingual caruncle, which are rounded sections of soft tissue on either side of the lingual frenum, house the Wharton's duct. In order to assess the salivary flow, we use our 2x2 gauze and dry the caruncle and gently milk the gland and assess the rate and flow. And again, you see that saliva come right out of the duct, noting it was fast and serous. Lastly, we look at the base of the tongue using our mirror and assessing the depression of the alveolar ridge to the side of the tongue. Noting the tissue is within normal limits.